after IND for an infection for patients getting antibiotics to which MRSA is resistant versus to which MRSA is susceptible, which would imply that it doesn't really matter whether you treat them or not. So in all 6 studies, there was no difference in resolution for antibiotics versus no antibiotics, or antibiotics that weren't effective against your infection after IND. But that doesn't answer a lot of questions. So they didn't tease out who had overlying cellulitis and who didn't. And what if we tried to treat patients with antibiotics MRSA is susceptible to? Would that include our success rates? Improve, sorry, our success rates? So this study looked at that. It came out the same year. So it was a retrospective cohort study of community-acquired MRSA skin and soft tissue infections done in Arkansas. So they only included patients in their study who cultured positive for MRSA. Included everything from culturable cellulitis to abscesses. Excluded anything really minor like impetigo. Excluded anything major with an underlying disorder like osteomyelitis. And they defined treatment failure as infection worsening after 2 days and greater than 1 of requiring a second IND, hospital admission, a new skin and soft tissue infection, or microbiologic failure, which was culture of MRSA from a wound after they completed their antibiotics. Their time 0 from where their 2 days started was the time at which the IND was performed for most of them. About 20% of the patients didn't get IND, so that time 0 was when their wound was cultured. So like I said, 80% had an IND. Therapy failed in 5% of the active antibiotic group and 13% of the inactive antibiotic group, which was a significant difference. So active antibiotics were antibiotics that had activity against MRSA. So that would suggest that treating MRSA abscesses with antibiotics after IND may prevent treatment failure, but 20% didn't get an IND. So I guess the bottom line is that MRSA abscesses may benefit from antibiotics, but there's been no large randomized double-blind placebo-controlled trial done, so it's really still up to clinical judgment.
Heather, that when you said there was failure, it looked like that was a composite outcome. And it could have been one of the 4 different items, and one of those was microbiological failure,
yes,
which is always very questionable. Do you know what percentage of those, quote, failures were microbiological failures, which are clinical failures?
I don't, and I don't think it said it in the study because I don't recall reading it. So I don't know the answer to that. So the second case that I'm going to talk about was a healthy 39-year-old male. He presented to a community emerge complaining of a red and painful left arm for the past 3 days, so sounds kind of like the last guy. No trauma associated with it. He'd already been on outpatient ceftriaxone for 3 days in the community. He's febrile, still feels unwell. His erythema is spreading, and this is what it looked like. So you can see the different lines where people have kind of drawn things over the past few days, and it continues to spread beyond borders. And that made me question, in this era of community-acquired MRSA, are we still looking at the same bacteria causing diffuse non-culturable cellulitis? And there's 2 studies that have come out recently looking at that. Well, a review and a study, I should say. So this study looked at the role of beta hemolytic strep in causing diffuse non-culturable cellulitis, and that came out a couple of years ago. So it's a prospective study at a California county hospital. And they had 248 patients with diffuse non-culturable cellulitis, so not associated with some kind of purulent wound that you could culture. They excluded people who had perineal, periorbital, or groin locations, anybody who could have had an opportunistic infection like people with neutropenia, different bugs involved, so animal or human bites, underlying disorder like osteomyelitis. And they also excluded people that had a soft tissue infection or pharyngitis in the past year because the way that they determined who had had beta hemolytic strep was by doing serologies, so that would have potentially interfered with that. And the way that they figured out who had which organisms in non-culturable cellulitis was a bit of a roundabout way. So they looked at anti-streptolysin O antibodies and anti-DNase B antibodies measured at baseline and then 2 to 12 weeks later. So ASO measures, those antibodies are antibodies to group A strep, group C strep, and group G strep. And ADB are antibodies to group A strep. So they also Sorry, I should say that typically in infection, your titers should rise within about 2 weeks and then start to decline about 3 to 6 months later. So it should be a parent who has an infection because it should be a certain amount of rise, and then they should be above the upper limit of normal for adults on their second titer. And only 2 to 5% of normal adults would have titers over the number that they had as their upper limit of normal. They also looked at blood cultures as well to kind of capture the people who had group B strep because they weren't using antibodies that could look at group B strep. So their secondary outcome was looking at response to beta-lactams, and that was analyzed by assessing clinical improvement after greater than 48 hours of treatment. So the physicians were asked to use gram-positive beta-lactams, and for the most part, they complied with that. So most patients, 83%, were treated with cefazolin. Most of the rest were treated with oxacillin. And then a handful of patients got things like Pen-G, ceftriaxone, clavulin, piptazo. So that response to beta-lactams could only be done because they weren't determining who got what treatment. So that response could only be measured in people who were not covered for MRSA. So they only measured response to beta-lactams in people who'd gotten 1 dose or less of MRSA covering antibiotics. So they could get 1 dose of an MRSA active antibiotic in the emergency department, but that was it. So there was 248 patients enrolled. 69 cases had to be dropped. They couldn't be assessed for repeat serology because they were lost to follow-up. So they might have completed their initial hospital stay of 48 hours or whatever, so they could be assessed for a beta-lactam response, but because they never showed up to get their repeat serology done, we don't know what they were infected with. So 179 people had a complete evaluation, and 131 of those were positive for beta hemolytic strep. So everybody was assessed for a beta-lactam response, but they had to drop a significant number of people who were unevaluable because they got less than 48 hours of treatment, i.e. they left AMA or were discharged early, or they got more than 1 dose of an antibiotic with MRSA. So you can see that the people who actually were assessed for beta-lactam response, largely it was successful. So there were very few treatment failures, even in the group that wasn't positive for beta hemolytic strep. But there were a lot of unevaluable patients. So at the end, 73% of patients had a beta hemolytic strep infection. 96% responded to beta-lactams successfully, and that includes the group of beta hemolytic strep negative patients. There's obviously some issues with interpretation of this study. So positive serology doesn't include co-infections. So some of these infections could have been polymicrobial. There was a very large unevaluable group of patients. And I don't know, Dr. John can correct me if I'm wrong, but I don't think that serology doesn't necessarily mean the infection itself was caused by beta hemolytic strep. Maybe it was caused by something else that just provided a portal of entry in the skin for beta hemolytic strep. Maybe that wasn't the original pathogen. So even in the era of community-acquired MRSA, beta hemolytic strep may be still the most common cause of diffuse non-culturable cellulitis. So this is a study that came out the same year with kind of a conflicting point of view. And this was a systematic review of the etiology of cellulitis with intact skin, so kind of a similar group of people. And they looked at studies that had used needle aspiration or punch biopsy to try to culture people's cellulitis where there wasn't anything that was culturable. So they, again, excluded similar people, so ocular, odontogenic infections, anything deep tissue or involving another organ, which they defined as an abscess or osteomyelitis. Any things that were thought to be contaminants, like staph epidermidis, were excluded. And anything involving a skin break was excluded as well. So in the end, they were left with 808 patients in total from 16 articles. 127 had positive cultures, 65 of which grew Staph aureus, 35 grew group A strep. A very small number grew other beta hemolytic strep. So the most common etiology of cellulitis in this study was actually Staph aureus. However, most cultures yielded no organism, so the vast majority yielded no organism. So maybe the real culprit is just more difficult to obtain or culture. Some of the studies were older, so we can't really make any comment about the proportion of them that were MRSA, because it was before that proportion would have been higher. So I think that the bottom line is that even in this era of community-acquired MRSA, probably most non-culturable cellulitis is still caused by MSSA and group A strep. So what they suggest in those articles is to start with a beta-lactam and then broaden coverage if treatment failure at 2 days. And patients allergic to beta-lactams could maybe just start with clindamycin, since that has some MRSA coverage. I guess another approach is to treat people with risk factors or those more likely to fail treatment. You could broaden their coverage empirically. So I think most of us were at research day when Danny was talking about his research about factors independently associated with treatment failure, which included fever at triage, leg ulcers, edema or lymphedema, and a prior cellulitis in the same area. So I guess that's another approach that we could do. The last question I had was whether or not ceftriaxone is a good choice for moderate to severe cellulitis. It's kind of a hard question to answer because I couldn't find any studies directly assessing its efficacy in adults. And for those of you that have done Hulk, you'll know that our surgical colleagues don't really agree with our use of ceftriaxone because it doesn't have good gram-positive coverage. So it's a third-generation cephalosporin. So first-generation cephalosporins like Ancef theoretically should have better gram-positive coverage. So that's why I wanted to look into this. If the majority of cellulitis is still caused by beta hemolytic strep and MSSA, then it might make more sense to choose something with better gram-positive coverage. But as I'm going to talk about clinically, that's not really how it turns out. So this was a Sentry antimicrobial surveillance program study, and it looked at about 12,000 strains of staph and strep that were obtained in Canada and the US, and then it tested their sensitivity to ceftriaxone and 12 other antibiotics. So it's a pretty big undertaking. These samples were isolated from a variety of different places, unfortunately, not just skin. So to kind of take that into account, I guess. And they looked at susceptibility in vitro. So almost 100% of the beta hemolytic strep in this study were susceptible to ceftriaxone. Only 60% of Staph aureus, some of which would have been MRSA, so I don't think that's a really surprising finding. 53% of coag-negative staph, like, for example, Staph epidermidis. And then about 90% of viridans group streptococci, which I think is a pretty low virulence organism for most people who are not immune suppressed. So in vitro susceptibility doesn't necessarily translate to in vivo, so numbers might actually be lower in vivo. Both MSSA and MRSA strains were used, and we wouldn't expect ceftriaxone to have any action against MRSA. Not all organisms will be necessarily representative of those found in SSTIs either, because they were cultured from a variety of different places. So in vivo, there's a few different studies that look at Ancef and compare it to ceftriaxone in a clinical setting. I picked this one just because it was the most recent that I could find. And it compared Ancef plus probenecid to ceftriaxone plus placebo in the treatment of moderate to severe cellulitis in adults. So this was a randomized double-blind equivalence trial on 134 cases of moderate to severe cellulitis in Australia. And they defined their cellulitis as recent onset soft tissue erythema with more than one of pain, swelling, lymphangitis, fever, and ulceration with or without discharge.